Good morning. The subcommittee will come to order. We thank you for your participation today. It's a pleasure for you to join us, for us to have you join us as we embark on what promises to be a challenging and I would hope historic consideration of how best to reform the healthcare system of our country. We're very fortunate to have a range of talent on this subcommittee on both sides of the aisle, and it is my intention, along with my friend Mr. Klein, to try to draw upon each of those talents of the members of the subcommittee in the best way we can to produce ideas and a work product that meets the President's mandate, the President's challenge to try to enact legislation in 2009 that reforms our healthcare system. I want to say from the outset how pleased I am to be able to share this responsibility with Mr. Klein for the second consecutive Congress. He is a person who is well versed on the issues, is very easy to communicate with, believes deeply in his views and is a strong advocate for them, but is also a fair and balanced person, and it's a pleasure to work with him. And I feel privileged to have this opportunity once again. I'm honored to be joined today by my science and technology advisor, my 16-year-old daughter, Jacqueline, who was bitterly disappointed that she didn't get to go to the Usher hearing. This is her consolation prize. Small consolation indeed. And also pleased I'm able to be joined by my cousin and her husband, Laurel Shull and Walt Shull. They're very important people in my life, and they give me a way to understand these issues. They're both retired educators. They work very hard for their health insurance over the years, and it's very important to them as they continue in their lives. And they, among many other people, give me a prism through which I can understand these issues. So I'm delighted that you're here today. On Thursday at the White House, President Obama challenged the Congress and the country to enact health care reform legislation in 2009. This will be this subcommittee's first effort to meet that challenge and rise to the occasion. The President, I think, very well articulated what most Americans want. I think he articulated the consensus of what Americans want when it comes to change in health insurance. First of all, I think most Americans want to choose their own doctor or health care provider. We feel very passionately that we want to be connected to the person we've chosen to be the pediatrician for our children, or the OB/GYN for our wives or daughters, or our own dentist, our own psychiatrist, whatever it is that we want to deal with. Americans feel very strongly about the sanctity of the doctor-patient relationship, and I believe we should do whatever we can to preserve and enhance that relationship. The second thing that I think most Americans believe about health care is it's costing them too much out of their take-home pay. Health care out-of-pocket costs for Americans have risen about 5 times as quickly as wages have risen in the last decade or so. That means for a lot of Americans who are fortunate enough to have health insurance, to have a job, and to have received a pay increase in that job, that they very often find they took a pay cut anyway because their out-of-pocket contribution to health care went up by more than their paycheck did if they're among that increasingly dwindling group that has a job and gets a pay raise. So I think most Americans understand that they want health care costs to eat up a smaller portion of their paycheck or their family wealth. That certainly goes for small businesses as well. Small businesses, all businesses, but particularly small businesses, are struggling to cover the people who work for them and their families, and finding it increasingly difficult to do so. 169 million Americans derive their health insurance through an employer-employee relationship. And it is for that reason that this subcommittee and the full committee will be actively engaged in the process of writing and debating and eventually legislating bills on this subject. There are different views about whether the employer-employee system should continue to be a basis for the provision of health care. I believe it should be, but I understand there are different views. What I do assure all members of the subcommittee and the full committee is that we will have our full and robust opportunity to weigh in on that debate legislatively as the year goes on, because the employee-employer system is such an important part of the care that's presently provided. This morning, we're going to begin our examination of these issues with a focus on the question of how much it is costing employers who choose to insure to help carry the burden of employees and dependents of those who do not insure. Now, notice the formulation I use for this. Employers who choose to insure is recognition of the fact that in virtually all cases in our country, the law today is that whether or not to insure one's employees is a matter of choice. We're very fortunate that many, many American employers make that choice, and they cover collectively 169 million people. Other employers do not do so, some by choice and some by necessity. This committee fully understands that there are millions of American entrepreneurs who are struggling to stay alive, and they're not providing health insurance not because they're indifferent to their employees or because they do not understand the value of health insurance, but because providing health insurance would wipe out any net profit they have in their businesses. It's simply not a viable option for a lot of businesses in the country. There are other employers, however, who are not insuring their employees as a matter of choice and not of necessity. It's within their business purview under present law to make that choice. There are a variety of reasons for making that choice. Some are presumptively legitimate, some are probably illegitimate. The purpose of today's hearing is to quantify and understand the cost of that choice that has been made. In other words, for employers who are in a position to provide health insurance but who choose not to, what happens to the people who are not insured and who pays for their care? This morning, I'm certain, as we meet, there are at least hundreds of thousands, probably millions of Americans receiving care in doctors' offices, hospitals, clinics, and other settings, and they're not able to pay their bill. When they're not able to pay their bill, someone else pays for it. We have a system in this country, and I'm thankful that we do, that people are not turned away, at least they're not supposed to be turned away, when they approach an emergency room or another health care provider and don't have an insurance card. I don't want to live in a country where people are turned away under those circumstances. But when they are accepted in that emergency room or accepted in that medical practice, someone pays for the care that they receive. In some cases, that someone is a health care institution or provider who simply eats the cost and provides free or reduced price care. In other cases, that cost is passed along to other people who pay premiums in the health care system, in which case the cost is passed along to each of us who pays health care premiums in some way. In other respects, that cost is passed along to taxpayers when uninsured people are covered by public programs, whether at the state or federal level. So our focus this morning is going to be to focus in on the question of how much is it costing for the employees who are not insured when they access health care, and who's paying for it? I think that's an important question as we go forward to frame this discussion. Again, I'm very grateful to have a chance to work with the colleagues that we have on this subcommittee. We're very grateful for this morning's panel. And at this time, I'd like to turn to my friend and the ranking member of the subcommittee, Mr. Klein, for his opening statement.
Thank you, Mr. Chairman, for your kind words about me and your other colleagues. I, too, am looking forward to working with you and our colleagues on this committee. I'm delighted to see that you have a very, very special guest here this morning. It's a pleasure to meet her. I don't have a special guest here this morning, but I would like to yield for just a moment to Mr. Wilson, who does.
Thank you, Ranking Member Klein. It's an honor that I have with me today shadowing the Honorable Piro Nasura. Member of Parliament Nasura is a member of the East African Legislative Assembly. She's a parliamentarian representing Uganda.
Please stand, Ms. Nasura, so we can recognize you. Thank you for coming. Welcome. It's great to have you with us. Thank you, Mr. Wilson.
Thank you, Mr. Wilson. Again, thank you, Mr. Chairman. I want to thank the witnesses for being with us today as we take up this morning's work. As the Chairman said, we began this in the 110th Congress, addressing many of the issues confronting our nation's health care system. including efforts to improve health care quality, access, and affordability, and clearly we are going to be doing it again in this Congress, not only in this committee, but across the board. An important lesson we learned during the last Congress was that, though imperfect, the employer-based health care system has been successful in many ways. As we try to address weaknesses in the current system, we must be careful not to undermine a voluntary approach that provides the most common form of health care coverage for individuals and workers below retirement age. The current employer-based voluntary system delivers high-quality coverage for over 160 million Americans. American businesses are true innovators when it comes to improving the health care system. Private sector employers are leading efforts to help people improve their health through wellness and disease management programs, improving the quality of health care, and helping people learn the true costs of medical services. The driver behind the successes of the employment-based system is the federal ERISA law. The existence of ERISA and its preemption of state insurance laws means that American businesses can provide uniform, high-quality benefits to all their employees across state lines. And that means companies don't have to worry about following 50 different sets of rules in order to offer insurance, which prevents headaches and saves money. Notwithstanding the success of ERISA, employers, employees, and their families are very concerned about rising health care costs. While we explore solutions, I want to caution against proposals that would undermine ERISA by pulling one string at a time. However well-intentioned, doing so would be an invitation to add benefit mandates and increases taxes on employers, which would likely stifle job creation and seriously undermine employers' ability to provide efficient, affordable health care coverage. At the same time, I would be remiss to not recognize the fact that ERISA stands at the crossroads of health care reform, which makes it all the more important that we do not unravel the system, but rather initiate comprehensive reform. Finally, attempting to define good actors and bad actors in the employer-sponsored system is fraught with danger. When we explore the issue of the uninsured, we must be mindful of the dangers of assigning a one-size-fits-all solution which may be difficult because of the different characteristics within a given population. For example, millions of people who already qualify for government programs have failed to take advantage of that coverage for a wide variety of reasons. Creating costly new programs to insure such people, which would come on top of existing federal and state subsidies for uncompensated care, may not be necessary or wise. In addition, we must not forget that this committee has taken the lead in efforts to improve the current system, including efforts to help small businesses obtain affordable health coverage comparable to that provided by large companies. Private voluntary efforts to control health care cost growth and improve quality can be accomplished more quickly than using government programs and should be encouraged. I'm hopeful we can continue to work together to reach consensus on measures to provide more affordable and efficient ways of providing health care benefits. I look forward to this morning's hearings and again thank our witnesses for being with us today. I yield back.
Thank you, Mr. Klein. Well, welcome, ladies and gentlemen. Here's the procedure we're going to follow. We have received your written statements, witnesses, and they will be entered into the record without objection. Also without objection, the opening statement of any member of the subcommittee who wishes to submit an opening statement will be submitted to the record. We will ask you, ladies and gentlemen witnesses, to to give us a 5-minute synopsis of your written testimony this morning. Again, we've had access to your written testimony, had a chance to review it. You'll notice in front of you a light box. The green light means you can start talking. The yellow light means you're within a minute of your 5 minutes being up. The red light means we would ask you graciously to stop. When we started this process a couple years ago, I mistakenly told people that there was a trap door underneath your seat, and if you talked beyond the 5 minutes, it would open. The trap door did not exist at that time, I will confess, but I'm not telling you whether it does this morning or not. So we'd ask you to, the reason we ask you to adhere to the 5-minute rule is that, as you see, a number of members are here. It gives the members a chance to interact with you and ask you questions and learn from you. We're going to now read the biographies of the witnesses, and I'll start with Mark Derbyshire. Mr. Derbyshire, welcome. He's the owner of Park Moving and Storage in Aberdeen, Maryland. Mr. Derbyshire is a small business owner who's going to tell us about his current struggles with the high cost of health care for his employees. Welcome, Mr. Derbyshire. Bruce Pyenson He's a principal and consulting actuary in the New York office of Milliman Incorporated. He's been with the firm since 1987 and works with employers, providers, HMOs, and healthcare businesses. Mr. Pyenson has authored several reports on healthcare reform, among other topics. Welcome, Mr. Pyenson. It's glad to have you with us. John Sheridan is the president and CEO of the Cooper Health System in Camden, New Jersey, the hospital at which I was born. The hospital overcame that setback and has thrived since then. Mr. Sheridan is responsible for the operations of Cooper University Hospital and more than 50 satellite offices. Mr. Sheridan has been with Cooper since July of 2005. Prior to that, he was a senior partner and co-chairman of the law firm of Riker, Danzig, Scherer, Highland, and Peretti. Mr. Sheridan graduated from St. Peter's College and received his law degree from Rutgers Law School. John, welcome. Nice to have you with us this morning. Mr. Courtney is going to introduce our next witness because he hails from Connecticut.
Thank you, Mr. Andrews, and thank you for holding this hearing today. We could not have a hearing on insurance without a witness from Connecticut, because as everyone from Woody Allen on down has observed, that Connecticut and insurance are synonymous. And Jim Winkler from Hewitt & Associates in Norwalk, Connecticut, is here to testify this morning. Hewitt & Associates is a firm that consults with employers all over the world and certainly all over the country. He's intimately familiar with, again, a lot of the pricing issues, quality issues, which are critical to us coming out with good ideas in this committee. And he's a graduate of University of Notre Dame and has an MBA from the University of Hartford. And I yield back.
Welcome, Mr. Winkler. Glad to have you. Neil Troutwine's returning to the committee. He joined the National Retail Federation in 2006 and has served as its Vice President and Employee Benefits Policy Counsel since that time. Mr. Troutwine previously was an Assistant Vice President on Human Resources Policy at the National Association of Manufacturers. He holds a bachelor's degree from the University of Louisville and a law degree from the George Washington University. Welcome back, Mr. Troutwine. Glad to have you with us. And then our final witness, Dr. Thorpe, hails from Dr. Price's district, so I would yield to him so he can do that introduction.
Thank you, Mr. Chairman. I appreciate that. I'm privileged to introduce Dr. Ken Thorpe, who is a Robert Woodruff Professor and Chair of the Health Policy and Management Department of the Public Health School at Emory University, where I did my residency training. He currently teaches public health and health resource allocations and health policy. From a public health perspective, he has always been knowledgeable and productive in his work. I've had the privilege of working with him as both a physician and as a state senator, and we welcome him here today. He received his BA from the University of Michigan, my alma mater as well, his master's from Duke, and a PhD from the Rand Graduate Institute. So he is a huge Wolverine fan, so go blue, and welcome, Dr. Thorpe.
You guys didn't do very well last year, did you? That's all right. We have a lot of Michigan people associated with the committee too, so that's okay. That's okay. All right, we're gonna start with our first witness, Mr. Devonshire. Welcome. We're going to proceed with the witness testimony and then begin with questions from the members. So welcome, Mr. Devonshire. Happy to have you with us.
Okay, thank you for having me. Again, my name is Mark Derbyshire. I'm the owner of Park Moving and Storage in Aberdeen, Maryland. My parents started the business in 1956 as a small company. And Aberdeen is outside of Baltimore. It's a small town. And in the area, there are many small businesses that we have to compete for employees from my industry and from other industries. I currently have about 30 full-time employees, and I invest a lot of time into them because I want to attract people who are interested in staying with the company for a long time. One of the benefits I'm most proud of is, of course, providing health insurance. Times are tough. Good workers are looking for the best opportunities. It is important to me to limit turnover so I can try to make sure that the people I invest my time and energy are committed to the company. I do not want to train people that might leave as soon as something better comes along. I have learned that higher compensation, the higher the motivation, and that is one of the reasons I provide health insurance. Also, I know my workers want to give 100% to their jobs, but if they have health problems that are left untreated, they can't. That hurts them, and it hurts my bottom line. It is not easy to provide health. It is not easy to provide health insurance to all the employees. Every year, the premiums go up, And every year, I've got to go back to the employees and ask them for a little bit more. Right now, I am paying 85% of their premiums for individual rates and 75% for the family rates. I can't continue to pay more. Year after year, the premiums are going at double digits. Often, we small business owners are attacked for not providing health insurance. What people fail to realize is that high cost of administration coverage for each employee, in addition to the rising cost of premiums. For a small business, the increased costs for fuel and raw material, along with the decreased revenue, can be a lethal combination. Many of my fellow business owners have been struggling with the idea of ending employees' health insurance to reduce overhead. All around me, companies fold under the pressure of rising health costs, and they stop offering the benefit altogether. That choice, I hope, will not be one I have to make. I worry about what would happen to our employees if they do not have health insurance, and I cannot afford to have productivity decline because people are sick. Businesses like mine that do not provide health insurance end up bearing the brunt of the cost for the uninsured workers of other companies. That hardly seems fair, especially for small businesses like mine, that tight profit margin. It is difficult to provide insurance for my own workers. I cannot afford to have premiums go up every year to help pay for the care of uninsured workers of other businesses or my competitors. When those uninsured workers end up in the emergency room, the cost of that care shows up in the hospital bills for my workers. My insurance companies, in turn, passes these higher costs to me in higher premiums. Those of us who do the right thing by providing health insurance now have to bear the unfair burden placed on my businesses that do not do their fair share in paying for health care costs. It is a vicious cycle. When premiums go up, businesses drop coverage, resulting in more uninsured workers. Those of us who continue to do the right thing by providing insurance get left holding the bag. Every year, that bag gets heavier. This year, I do not know if I'm able to continue paying for coverage for families. I try not to think about what would happen if I get rid of this benefit, what would happen to my employees, their kids. Worry that some people will look for other jobs and that they might have a tough time finding the same caliber of hardworking, high-quality employees. If all businesses were required to offer health insurance, the burden would be lightened for all of us that are providing health insurance and all businesses. Businesses like mine need the federal government to help us level the playing field. All businesses should pay their fair cost of health coverage so that none of us have to take the extra burden. Thank you.
Thank you, Mr. Derbyshire, very much for your testimony. Mr. Pyenson, welcome. I think you need to push the on button on your microphone there.
There we go.
And if we don't like what you say, push it and we'll turn it off, okay?
Well, good morning, Chairman Andrews and members of the subcommittee. It's really my honor and privilege to be speaking to you today. I'm Bruce Pyenson. I'm an actuary with Milliman. It's a consulting firm, and we consult to a broad spectrum of the healthcare industry on actuarial issues and healthcare management expertise. We've seen, even before this economic crisis, that the cost of healthcare has made it more and more difficult for employers and others to buy health insurance. And that, of course, has only gotten worse with the recent crisis. In my view, the most important and the single most important issue is the high cost of health care. It should be the #1 issue in the healthcare debate, and I was gratified to see that mentioned very prominently in the recent summit. 2 weeks ago, a few of my colleagues and I published a report entitled Imagining 16 to 12, which refers to the current spending of the United States on healthcare at 16% of GDP, and the fact that the enormous amount of waste in the system accounts for at least 25% of that. In fact, we say that we can reduce our spending by becoming more efficient from 16% to 12% and still cover the uninsured. Much of the spending in the healthcare system today goes to services or administration that could be done more efficiently or do not bring value to patients. And even worse, some of that spending goes to services that harm the patient or fix mistakes that should not have been made. Fortunately, the magnitude, that huge magnitude of waste, is illuminated by points of excellence in our healthcare system that exist in locales around the country. And you can actually apply those examples of excellence to the national averages and come up with numbers like what we came up with in our report, that we could dramatically reduce healthcare spending. Now, to get to 12%, we developed actuarial models that composite the best practices from those locales, and we applied those models to the entire U.S. So while our models show that we can reduce healthcare spending by 25%, we could actually reduce it by more than that and use the savings to cover the uninsured. That's not unique to our study. There's been a number of others that have come out with studies that show that considerably more than 25% of healthcare spending is waste or inefficiency. We consider that 12% as a target, not as a budget, but it's a foundation for consensus on healthcare. In short, we think that rationalizing care, efficient use of resources, is far superior to rationing it. Now, as with any economic change, there's winners and losers. In my view, the biggest winners in a more efficient healthcare system will be the consumers and the patients and the uninsured. Other winners will be those that can adapt to a system that has incentives for efficiency. And of course, the losers will be organizations that can't adapt to a quality and efficiency-based system. Our report includes recommendations for system and reimbursement change. I believe those can win consensus. In short, it means shifting payment and care towards evidence-based practices to reduce hospitalizations, avoid unneeded diagnostics, shift long-term care from nursing home to the home, and provide better quality care at the end of life. And again, patients will be the big winners. However, I think a focus on reducing cost is actually much harder than arguing about which of the tactics to adopt. Chairman Andrews, at the White House summit last week, you raised important issues that employers who offer health benefits indirectly pay for cost shifting from those who don't. I think many issues go into the calculation of premium rates for insurance. I'd point out that employers also pay for cost shifting from inefficiency and not just within their own programs. Driving down the cost of health care makes all of that much more practical. I'd like to note in closing that Milliman itself does not endorse any specific legislation, and I'm presenting the views that are found in the report.
Thank you very much, Mr. Pyenson. We appreciate that. Mr. Sheridan, welcome to the committee.
Good morning. Mr. Chairman, thank you for the opportunity, and also to your fellow members of the committee for the opportunity to address you this morning. I'm the president and CEO of Cooper University Hospital, which is based in Camden, New Jersey. It is a major teaching hospital and a regional tertiary care center serving southern New Jersey. It is also a level 1 trauma center, and we are the clinical campus for the Robert Wood Johnson Medical School in Camden. Camden City is one of the poorest cities in the United States, with approximately 40% of its households living below the federal poverty level, and Cooper is the city's main healthcare provider. While the national recession has impacted Cooper's finances, the Camden environment and its poor economy has presented financial challenges to us for decades. We have managed to grow over the past 8 years by recruiting some of the top doctors in the country and developing clinical centers of excellence. And this has enabled Cooper to attract New Jersey residents who at one time relied on the major medical academic centers in Philadelphia for their health care. Our strategy is to attract suburban insured patients to help us carry out our mission for the people of Camden. Cooper's payer mix represents a microcosm of the the healthcare financial dynamics at work in New Jersey. Those without health care insurance and patients qualifying for charity care and Medicaid totaled over 38% of Cooper's patient base in 2006, and this number has grown over the past 3 years to nearly 41%. Cooper receives state funding for its charity care services, but they cover only about 50% of the costs. Medicaid funding typically in New Jersey covers 60 to 70% of costs. Thus, for Cooper, this uninsured and underinsured population combined represents approximately 30% of our costs over the past 3 years, but only about 15% of our revenue. The reason why 38% of Cooper's patients account for only 30% of revenue is explained by the fact that the uninsured typically use hospitals for less acute primary care type services. Thus, their hospital cost per person is lower than average. However, this represents a huge misallocation of resources in our healthcare economy, in that expensive hospital resources are being utilized to provide that which could be done very well at the primary care physician level. What are the economic consequences of this pattern? Hospitals such as Cooper must shift expenses to those with health insurance. Patients with employer-sponsored health insurance constitute just over 30% of our patient base and approximately 30% of our cost. However, this segment of our business over the past 3 years represents about 40% of our revenue. Unfortunately, these underlying dynamics of our healthcare economy are not sustainable. As costs are shifted to the paying patients, premiums rise, and individuals and businesses are unable to pay for health insurance coverage. This increases the number of uninsured and underinsured, which leads to further cost shifting. The picture I have drawn of Cooper and the healthcare economy in Camden can be found throughout New Jersey, albeit to a somewhat lesser extent in the state as a whole. Over the last 6 years, the percentage of uninsured charity care and Medicaid hospital cases have grown from 14.8% to 18.5%. Insured cases have declined from 47.6% to 41.9%. During the same period, provision of hospital charity care service priced at Medicaid rates grew from $624 million to $945 million annually. This represents an annual growth rate of 8.6% per year. These trends regarding the decline of healthcare coverage and increase in uninsured and underinsured in New Jersey have taken a serious toll on the hospital industry. More than half of New Jersey's hospitals are operating in the red, and 8 hospitals have closed their doors since 2002. In conclusion, it would seem clear that employer-sponsored health care insurance has been and will continue to be crucial to the financial health of hospitals such as Cooper and New Jersey's healthcare economy. However, businesses have a right to be seriously concerned about the increasing cost of health care. The trends are not sustainable. The cornerstone of health care reform is the expansion of insurance coverage to all Americans, and employer-sponsored plans will play a key role. It will also be important for there to be stability in health insurance premiums so that businesses and individuals are able to adequately plan to meet their obligations. This, in turn, will require a decline in the rate of health care cost inflation. We stand ready to do our part to better manage care and reduce unnecessary hospitalizations and improve the quality and cost efficiency of health care services. Thank you.
Mr. Sheridan, thank you very much for your testimony. Mr. Winkler, welcome to the subcommittee.
Mr. Chairman and members of the subcommittee, thank you for the opportunity to testify at this important hearing. My name is Jim Winkler, and I am the Health Management Consulting Practice Leader at Hewitt Associates. At Hewitt, we consult with large employers, helping them improve employee health and reduce absence through better program design. In addition, we are the leading provider of benefits outsourcing services, administering health and welfare benefit programs for 195 employers representing nearly 8 million participants. I'm pleased to focus my remarks today, as requested, on the experience of large employers, the majority of whom do provide health care coverage today. While large employers are not a homogenous group, I do want to be clear in saying that employers and Hewitt support the concept of healthcare reform and believe that all efforts to cover working Americans should build upon and further strengthen the employer-based system which provides coverage to more than 160 million participants today. Employers have a vested interest in the health and productivity of their workforce, and the employer-based system has helped foster that interest. However, despite the positive actions of employers, there are many problems to solve in the current U.S. healthcare system. As we all know, healthcare is too costly. Average annual healthcare costs for a typical large employer will exceed $13,000 per employee by 2014, a 50% increase over current costs. Both employers and employees will find it difficult to afford such an increase. We also believe that systemic changes are needed to reverse current cost acceleration. The federal government, employers, and health plans must work together to change the payment system to better focus physicians and hospitals on wellness, primary, and preventative care with strong incentives for evidence-based medical treatment. Finally, we spend too much on chronic conditions without measurable quality. We must attack the root causes of smoking, poor nutrition, obesity, and physical inactivity by providing financial incentives for healthy behaviors. This will not only lower healthcare costs, but will also reduce absence. This is critical as lost workforce productivity is a very real cost to the U.S. economy. The cost of healthcare for large employers and their employees is higher because of gaps in coverage and differences in reimbursement rates between public and private healthcare programs. Large employers pay somewhat higher premiums to cover provider costs for uncompensated care. Further, employers fund higher costs for medical treatments because Medicare and Medicaid payment rates are comparatively lower than rates for employer-sponsored group health plans. Large employers are concerned that cost shifting could increase further if rising healthcare costs encourage small and medium-sized businesses to drop health coverage in order to remain competitive, particularly in these difficult economic times. So how do we address these issues? In our written testimony, we identified 5 imperatives for healthcare reform, and I'd like to highlight 3 of them today. First is we need to preserve and promote the employer-based healthcare system that generally works, while imperfect, for 160 million people today. Second, we must protect and strengthen federal ERISA preemption of state laws to promote uniformity in coverage and reduce administrative costs. The vast majority of large employers operate across multiple states, and they must be able to continue to offer administratively efficient, uniform benefit packages to their employees. And third, we must allow employers flexibility in how they meet any new standards for health coverage. For example, they should be able to demonstrate that their plans are equivalent in value to any standard benefit requirements, similar to the rules in place for the retiree drug subsidy under Medicare Part D today. As I noted at the outset, large employers support health care reform that will lead to sustained affordability for themselves and their employees. How large employers react to specific reform proposals will depend in large part on the many critical details in any proposed reform, and whether or not large employers view that specific reform as likely to increase versus mitigate their health care costs. The earlier that Congress can make details available for discussion and analysis, the better that employers can react. Congress has the challenge of sorting through the details of how reform will be accomplished, with competing approaches and viewpoints. Hewitt would be pleased to offer its data analysis and its experience in helping the subcommittee evaluate the impact of detailed reform plans on coverage provided by large employers today and in the future. Thank you.
Thank you, Mr. Winkler, and I'm sure that we will call upon you and your expertise for that assistance. Thank you. Mr. Troutwine, welcome.
Thank you, Mr. Chairman, Ranking Member Klein, excuse me, and members of the subcommittee. By way of introduction, the NRF is the world's largest retail trade association. We represent all retail formats and channels of distribution. We represent an industry with more than 1.6 million retail establishments everywhere from Main Street to commercial streets. We represent 24 million employees, about 1 in every 5 American worker today. We had 2008 sales of about $4.6 trillion, though obviously in the current economy that's a goal we won't reach in the coming year. We too strongly support the voluntary employer-sponsored health care system, even though times are tough and even though we have a tough population to cover. Even in the best of times, we endure wafer-thin profit margins, and it's really tough, particularly as you go down in size for many retailers to survive. We really have no choice in the current environment but to manage the cost of labor very, very carefully in as cost-effective a way as possible. Maintaining that balance between healthy workers and the running of the business is not always easy. In fact, it can be borderline impossible even in the best of times. I've attached the NRF's comprehensive healthcare reform proposal to the end of my written testimony. I'd be happy to answer any specific questions on this. But we share the concern among the panel on lowering healthcare costs. That really, to us, is the key to making healthcare reform work. The lower the cost of coverage, the more people who can obtain the coverage. I would like to focus on our shared goal of strengthening the employer-based system. As I noted, retailers by and large are still committed to this voluntary system even in these tough times. This mix of compensation, both wages and benefits, are part of how employers have distinguished themselves in attracting employees through the years. In a minute, I'll talk about an alternative to an employer mandate that we think makes better sense in terms of leveling the playing field. We share the concern of larger employers. In fact, we have many large retailers that the rising cost of care will threaten our ability to maintain the benefit. We also agree with President Obama that the current cost trajectory is unsustainable. We have to bring healthcare costs back down to earth. We also need to be able to find the quality in healthcare, something that's been sorely lacking. An NRF small independent retailer recently testified before another committee of this House that his customers know more about the pet products on his shelf than they do the doctor down the street, and that's something that we all can work to do to improve. People should be able to select the best quality care just as they choose between different retailers on a daily basis. I'd like to focus on three particular reform elements, some of which have already been discussed that some might have you consider. First, a mandate on employers to provide coverage or pay into a public fund we feel would have the perverse effect of lowering wages and lowering the number of jobs in the local community. In the current environment, we can't afford new government mandates or minimums on the coverage we offer. And I'd ask who will be available to pay doctor bills if do not have the jobs in hand to help pay for the coverage. We would urge consideration instead of an individual mandate to obtain basic health insurance coverage and thus leverage voluntary employer contributions, keeping employers in the mix in supplement of the basic benefit, and to help employees accept the coverage we offer. We have a number of employees who don't accept the coverage we offer today. Second, we would strongly urge you not to disrupt the federal ERISA law, which we agree with many of our panelists is the backbone of the employer-based system. Without ERISA, multi-state employers, and retailers are also multi-state employers, we couldn't offer common benefit packages across state lines. We don't agree with the proposition that ERISA preemption should only be brought to plans that meet federal minimums on the composition of benefits or on the size of employer contributions to plans. Unraveling ERISA will take employer dollars off the table and greatly complicate the task of achieving healthcare reform and universal coverage. Finally, we'd urge you to reject efforts to limit or eliminate the tax-favored treatment of employer-provided health insurance. Efforts to cap or eliminate the employee income tax exclusion could create a backlash against healthcare reforms as employees face higher taxes for benefits over the cap or lower benefits to stay under the cap. Enacting healthcare reform is going to be tough enough without creating big constituencies against it. Finally, in conclusion, I see my light is up. We want to be able to play a supportive, positive, and nonpartisan role in furthering healthcare reform. We really feel like the talking phase has gone long enough, and we hope to get to the enactment of the right kinds of healthcare reform ahead. Thank you, Mr.
Thank you, Mr. Trautwein, for both the spirit and substance of your testimony. Thank you. Dr. Thorpe, you're our cleanup hitter.
I appreciate that. Thank you, Chairman Andrews, Representative Klein, members of the subcommittee, Dr. Price for that kind introduction and for his thought leadership on this issue as well. We all know the statistics, but I'm going to give them to you anyways because they're grim. Since 1999, the cost of a family private insurance policy has gone up 119%. The typical family, either through lower wages or directly in premiums, pays about $12,600 a year on health care. So in healthcare reform, we've got to find a way to get to the root cause of why healthcare spending is rising. We can come back to that, but it really deals with the absolute explosion in chronic disease prevalence that's fueled by a doubling of obesity in this country. And secondly, the fact that 3/4 of our total healthcare bill is linked to chronically ill patients, that particularly in the Medicare program, we do a very poor job of managing. So we'll have to come back and deal with that. There are certain costs, as we've talked about, associated with employer-based health insurance that are less apparent than we see in the frequent tallies of spending. I'm going to focus on two of them. First are the costs associated with uncompensated care that's not directly paid for through federal or state sources. And second are the costs that employers bear who offer insurance for providing coverage to workers they don't employ, the spouses of their employees. In 2008, the last year we had data, for the 47 million people who don't have coverage, they incurred expenditures of over $57 billion. So we are paying through different sources and different arrangements for the health care bills of the uninsured today. This is a very fragmented, very unorganized, in a very uncoordinated way. When they can, hospitals and physicians shift the costs of these dollars that aren't explicitly paid for onto the costs of private insurers. This differential pricing is seen as a rational market response to the ability and willingness of some payers to pay more than others, similar to what you find in the airline and hotel industries. But regardless of what we call it, it's clear that private insurers pay more for health care and that these higher payments are used by providers to defray the cost of care for other patients, particularly the uninsured. On its most recent report to Congress, MedPAC reported that the average Medicare and Medicaid margins are projected to fall. This shortfall is made up for what MedPAC characterizes as unusually high hospital margins on private payer patients. That is, a private insurance plan on average pays about 20% more than the cost of care in order to offset the losses that hospitals and healthcare providers face from underpayments in Medicaid and from non-payments from the uninsured. There's a second significant cost shift to employers in providing health insurance, however, that's even more opaque than the cost of uncompensated care, and that's the cost of providing health insurance to spouses. Nationally, 51% of people under the age of 65 with private health insurance are covered through their own employer. Another 10% directly purchase private insurance, and the remaining 39% of individuals with private health insurance get coverage through their spouse and their spouse's employer. It's this last category I want to focus on. In 2006, there were 31 million families in which both adults worked. An analysis I conducted at Emory showed that more than half of those families, 55%, received health insurance coverage through one but not the other employer. Nationally, the costs of workers receiving health insurance through their spouses amounted to an increase of $46 billion in payments from employers that do offer health insurance. Employers who don't offer health insurance, for a variety of reasons that we can all understand, are called by some free riders because at least some of their workers get coverage via a spouse's employer. As we've heard, many small employers would love to have health insurance. It's oftentimes just very expensive and not affordable to do so. And so we need to find ways to make health care less expensive. Well, what are the costs of these free riders to businesses that offer insurance today? I already mentioned the one figure of $46 billion. Another way to think about it is that the incremental cost to employers that offer insurance of covering employees that are in firms that largely don't offer coverage is about $2,800 a year. So if you think about it, the rise in the number of dual working families combined with a decline in the share of employers offering health insurance is placing continued financial pressure on employers that continue to want to stay in the game. So we really have three problems in closing. One, we got to get to the fundamentals and find ways to make health insurance less expensive for everybody. And two, we've got to deal with the fact that we're doubling and tripling up on employers that offer health insurance, both through cost shifting from the uninsured, underpayments on the Medicaid side, and by the fact that employers that do offer insurance are paying for the costs of those workers that don't offer insurance. In closing, thank you for inviting me to testify.
Well, thank you, Dr. Thorpe, and thank to each of our witnesses for doing a very, very good job this morning and giving the committee a lot to think about. We're now going to begin the question phase of the hearing, and I'll begin. There are 30 million people who live in a family that's headed by someone, the 30 million uninsured people living in a family headed by someone who's working but uninsured. 30 million out of the 47 million. We've heard Dr. Thorpe testify that the cost of uncompensated care nationwide is about $57 billion a year. We heard Mr. Winkler testify that in premiums alone, a conservative estimate is that premiums are 2 to 3% higher for insuring employers than they would be but for this uninsurance problem. And I thought it was striking to hear Mr. Sheridan talk about the fact that at Cooper Hospital in New Jersey, 30% of their patients are people insured, but they pay 40% of the bills in the hospital. I think I got that right. So there's a significant cost shift there. I also think that we've heard a consensus, and I think this is very true, that improvements in quality and ways to address chronic disease problems is absolutely a major component of controlling costs. I don't think there's any doubt about that. But in addition to that, there is the problem of shifting the costs of uninsured people onto insured people. Mr. Troutman, I just want to focus on a person who might be in Mr. Sheridan's hospital this morning who makes $27,000, $28,000 a year, maybe working for one of your members or a similar employer, and is not insured. Her children are now insured because of S-chip, but she's not. And she goes into Mr. Sheridan's hospital because she has a severe problem and requires hospitalization. If I understand correctly, your proposal that you want to have us help deal with this is that we pass a law requiring her to get health insurance coverage, an individual mandate on her. In my state, that would cost her at a minimum, just for herself, at a minimum, between $2,500 and $3,000 a year, at a minimum. How's she going to pay for that?
Well, in our view, a better way to level the playing field and make sure that everybody gets basic coverage was ideally for the young woman in the hospital. She would have had preventative care, would have identified the condition.
But she doesn't. She's uninsured.
Exactly. I think everybody should have health coverage, basic health coverage, and we should also find a way for employers to stay in the game by supplementing that coverage with additional benefits. States could also supplement that coverage, but it is a dilemma for hospitals to pay for that treatment. It's a problem under current law.
But if I may, I think it's a dilemma for her, because your proposal is to pass a law saying she has to buy health coverage the way she has to buy auto insurance. How's she going to pay for it? Where's the money going to come from?
Well, I think we need to ease access in the marketplace. I think insurance is more expensive in New Jersey than perhaps ought be.
What if we achieved a 35% reduction in health insurance premiums, which I doubt very much we could do, and would cost her $2,000 instead of $2,500? How's she going to pay for it?
I think the federal government should subsidize access to income on an income graduated basis to that.
Well, now President Obama has talked about that as well, and he has proposed paying for that by repealing the tax cuts for the top 5% and by getting rid of the Medicare Advantage program. That's how he'd pay for it. How would you pay for it?
I'm certainly not a budget expert. The politician in me, or the student of politics that's in me, would say it would be difficult to support a proposal that concentrates on such a narrow slice of the tax tax scale and doesn't.
So you'd want to tax everybody, not just the top 5%?
Well, after all, access to health coverage has been a shared goal from many different constituencies for a very, very long time, and figuring out how we build on the employer dollars that are currently in the system, how we cover that gap for people who don't have access to employer-based coverage while maintaining jobs and building the economy is a tough job. And
It's a very tough
willing
job.
to work with you and others to get to that end.
We welcome your participation, and obviously I'm pointing out what I think is where the rubber will meet the road. And we sat in the White House last Thursday and heard a lot of very good-willed people talk about improving quality and productivity. I think we all agreed with that. Talked about the proposition that covering everyone will help reduce costs for everyone, which I think just about everybody agreed with. But the reality here, I think, is that short-term productivity improvements will never pay for the subsidies necessary to cover 47 million people. And the job that is in front of us is figuring out how to pay for that. And by the way, I commend you for making a proposal in your testimony. I'm not sure that I embrace an individual mandate. I certainly don't embrace it without a very sufficient subsidy to pay for it. But I think the Federation deserves a lot of credit for not ducking that question and raising the point that you did. We're now going to turn to Mr. Klein for 5 minutes.
Thank you, Mr. Chairman, and again, thanks to all the witnesses for really terrific testimony on a very, very tough subject, and one which, as I said in my opening comments, we're going to be dealing with as a Congress and as a nation as we try to work through what the new paradigm is going to be in providing health insurance. I don't think any of us sitting here today know exactly what that is. As Mr. Winkler said, the large employers, as I'm paraphrasing here, are sort of waiting to see what the critical details are. Well, as are we all, as we work towards what those critical details are going to be, because it's very, very important. The idea of everyone owning their own health insurance is one that appeals to many of us. Again, the devil, as they say, is in those details, or how are you going to pay for it? What's the federal government's role? What's the state government's role? How would you do that? And again, as I said in my opening statement, as we go through this, and I think that Mr. Winkler, Mr. Troutwine, and others probably all agree, we cannot afford to pull the string on the sweater, if you will, of ERISA and look around and find that we don't have 47 million uninsured, but over 200 million uninsured. With that, let me turn to Mr. Pyenson, if I could. Really an interesting study, and I think probably very helpful as we start to look underneath at how this is going to work. You commented that waste and inefficiency in the healthcare system exist, and everybody in this room would agree with that. There is no question. It is there in big, big numbers. And you point out that healthcare management experts know thousands of ways, I think that's in your testimony, to improve the system. Why hasn't this been done already?
Well, that's a great question, Mr. Klein, and thank you. The challenge of changing the healthcare system to make it more efficient is, in my view, largely one of the incentives that are in place in the current healthcare system. We're addressing the issue of here this morning of federal preemption on the employer space compared to the state regulation. I'd point out that there's a bigger issue with the federal and state counterpart, which is between Medicare and Medicaid. And the largest insurance company in the world is the federal Medicare program, and the interaction between Medicare and Medicaid has, in my opinion, been a destructive one for patients and for efficiency. We see that most profoundly in the interaction of patients in nursing homes on Medicaid, which is a huge issue, as we all know, for state Medicaid budgets. And unfortunately, with poor quality care, those patients often end up in the hospital where Medicare pays for their hospitalization. So the lack of coordination of getting better care to the nursing home patients, which the states can't afford to do, is a challenge. If they had better care, the benefit would accrue to Medicare. So fixing that interaction between the federal and state programs, I think, is one of the keys to creating incentives in place. The other piece of that, of course, is that no single insurer or employer has anything close to the clout that the Medicare program has.
I'm not sure that I'm not sure that answers the question of why we haven't improved the system. I mean, I would certainly agree, and I think most people in this room would agree, although I never presume to talk for the chairman, but it is clear that with Medicare and Medicaid, to follow up on your point, we hear complaints all the time about enormous waste there, but also about underpayment. We know stories of doctors and facilities, healthcare facilities, who are saying they won't take Medicare patients, for example, because the reimbursement rate is so low. So we have this huge insurer, if you will, in the federal government, a huge program that is not paying or is reimbursing at such low rates that people are turning it down. It does seem to me, and I know it's frustrating to all of us, that we all know of waste and abuse and inefficiencies. You've pointed them out, and yet we can't seem to get at those and to make the improvements. It looks like that employers and employees and providers would be clamoring for those efficiencies. Well, magically my time has run out here, so thanks very much. I yield back.
You notice that? The chair recognizes the gentleman from Illinois, Mr. Hare, for 5 minutes.
Thank you, Mr. Chairman. Thank you for having the hearing. It's a very important issue. Mr. Derbyshire, just a couple questions to you. What would you like to see the federal government do to help spread the burden of covering the uninsured? And then the second part of that question was, how can we as a government make it easier for small businesses like you to continue to provide health care coverage for employees?
What I would like to see, and is that, and I said in my testimony, I would like to see more employers all across the board be able to, there be a mandate that all employees pay sort of a tax to offset the premiums that I'm paying for now by insuring the uninsured, so that would, level the playing field and reduce my premiums and balance the cost of insurance among all employers and all my competitors.
Okay, thank you. Dr. Thorpe, what you, in your opinion, how can we guarantee coverage for these 47 million Americans, that, including 9 million kids who are uninsured? Do you know of any systems at the state level that have been successful, or do we need to just start from scratch, from your opinion, and completely overhaul this healthcare system?
Well, on the coverage side, I think that, as Mr. Traunwein talked about, I think you have to look at a requirement for individuals to purchase coverage, but with a caveat that if you're going to do that, to the chairman's point, that we have to make sure that health care is affordable. So we just can't require it, but we've got to make sure that what people pay for health insurance is reasonable, and that'll be part of the discussion that we have about health care reform. So, Massachusetts did this a year ago. They went from a very, 10% of the population uninsured. Now they're down to 3% of the population uninsured in a very short period of time. They could have done more on the cost side. They could have probably done more on the affordability side, but I think that's certainly, if we're going to get to universal coverage, we have to go the direction of requiring people, I think, to purchase it and make it affordable. On the cost side, that's where I think we do need more sweeping reforms. To the point that Mr. Klein was raising, why don't we do this? I think the problem is that to really get at the underlying cost drivers really means that we're going to have to do 3 things, and they're major things. One, we're going to have to change the way that we pay for health care, I think led by the Medicare program, to look more towards bundled payments, episode-based payments. 2, we're going to have to redesign our health care delivery system. If all the money in health care is linked to chronically ill patients, And if we have a delivery model that has very little to do with managing those patients, to keep them out of the hospital and keeping them from being readmitted to the hospital, then we need to really look very hard at redesigning our delivery model. And the third thing, which is a fairly sweeping reform, is that we need to do a better job of preventing disease in the first place. There are great models out there, great case studies that are school-based, community-based, workplace models that have lowered costs and improved productivity, that we need to understand how they're designed. We need to replicate them and scale them. So those are all going to be fairly major changes on the cost side.
Thank you. Then my last question would be to you, Mr. Winkler. You talked about several reasons why healthcare costs are so high. How much of these costs are administrative or caused by antiquated health information technology or record keeping? In other words, of this high cost, how much of this is just administrative and duplicative stuff that we're spending so much on? I've heard it's up to perhaps a third of what we're spending.
Really sort of two parts. Excuse me, two parts to that. One is the administrative cost that large employers have for coverage overall, which for larger employers generally runs 10 to 12%, a little different than for smaller employers. But to the point specific to healthcare information technology, we have seen estimates. We don't at Hewitt have a specific number, but I've seen estimates ranging anywhere from probably 20% on the low side to 30% on the high side. I think similar to what the gentleman from Milliman alluded to before, I think the challenge in capitalizing on that is figuring out not only how you broadly adopt technology, but what incentives you can build into the system for the medical community to use that, for patients to avail themselves of it, and then ultimately for the payment model to track along with that.
Thank you, Mr. Hare. Gentleman, Dr. Rowe is recognized for 5 minutes.
Thank you, Mr. Chairman, and thank you all for being here. It made my head swim to hear all this again, and I practiced in a facility like yours, Mr. Sherman, and just left one not long ago. Mr. Chairman, in Tennessee, we had a program called TennCare, which virtually bankrupted the state. The governor backed off from that and started a new program where the employer pays $50 a month, the employee pays $50, and the state pays $50. So there's a shared responsibility. And now it's not a Cadillac plan, but it is a basic health plan. And Mr. Winkler, what you said a moment ago is absolutely correct. Taking care of chronic disease is one of the biggest challenges I had in the practice of medicine for over 30 years, is to convince people to do that. And I think you have to change incentives. I think we're going to have to change incentives. Right now, I'm incentivized to take care of sick people. That's how I get compensated. And we've got to change that scheme where physicians and providers are compensated for wellness. We had a program in Johnson City, Tennessee, where I was mayor before I came here, and the city employees, where we did a chronic disease management, diabetes, hypertension, and cholesterol management. And right now, we're seeing our health care costs not go up at nearly the level of the national level. So those disease management programs do work. One of the things that I have become incredibly frustrated with, though, and actually, Mr. Pineson, I want you to kind of look at this. Back in the 80s and 90s, remember, managed care was going to be that was how we're going to control costs. And all we did was manage to shift that money around, but we didn't control the costs. And right now I hear information technology, and our practice just moved 70 of us. It was one of the most painful things I've ever done in my life, to change from a paper record to an electronic medical record. We have 70 providers and 350 employees in our practice, and that's been about a 2-year process to get there. Do you really think that a 25% reduction is possible, and are you talking with this information technology, or is this just another wistful thing that we're going about, another exercise I've seen once before?
Well, thank you very much, Mr. Rowe. I think information technology is certainly going to be very good for the information technology companies. If you examine the organizations that are extremely efficient and the locales that are extremely efficient, it's interesting that it's hard to attribute that efficiency to information technology. But of course, you know, information technology has to be a boon to everything, just as it has to the retail sector and every other sector, and I'm certainly not opposed to it. In the Imagining 16 to 12, we emphasized that we want people to imagine the possible. It's possible because we see those sorts of efficiencies in locales, typically with integrated physician practices, where the incentives are for the sorts of things that Dr. Thorpe and others this morning have addressed. And we believe those sorts of programs are using existing knowledge optimally. So I truly think it is possible, and it's really creating the environment where the talents and the skills of the medical professionals can really be used.
Chairman, Mr. Chairman, one of the things that you mentioned a minute ago I've spent a lot of time thinking about is where we have 47 million people in this country that are uninsured. And obviously the payments of Medicaid and Medicare don't cover the costs in many situations. And so that's an issue that hospital systems and physicians and providers have to deal with. But you've got half of the people who are uninsured are in families who work, who are offered insurance at their current business, but they can't afford it. It looks to me like some sort of tax credit or subsidy would help immediately take a lot of those people off the rolls. Any comment from any of you about that?
Certainly it's a problem for retailers with a lot of part-time workers. A third of our workforce is part-time, and getting those eligible for coverage to accept is a real problem. So we share your belief that subsidies can help get people into coverage. Tax credits can be a little bit cumbersome to administer, and it may be that a subsidy is a cleaner way to approach that, but we strongly support it.
Thank you, Mr. Chairman.
Thank you, Dr. Rowe, for bringing your experience and perspective to the committee. We're glad to have you with us, very much so. Now, different experience and perspective, one of the, I guess, three nurses in the House. Our friend from Long Island, Ms. McCarthy, who practiced nursing before joining us here in the House, is recognized for 5 minutes.
Thank you, and I thank you for the hearing. And obviously, I'm going to go to the nursing issue because it was mentioned on home care, end-of-life care. This is something that I certainly experienced because I did a lot of private duty during my nursing career. But with that being said, we're seeing a lot of the care, especially coming out of the hospital, going to healthcare aides. And the charges that a healthcare aide gets, her salary is probably, his salary is probably between $7 and $8. The company that she works for probably picks up a $13 or $14, or if not more, on that. And that's something I think we need to look at. But you can't just bring people home, even for end of life, unless you have the experience of someone being able to take care of somebody there. And that's where high tech does come in. A number of programs that we've seen in my hospitals out on Long Island, where there's a camera there to work with the aide and to work with the patient, so that an RN or a doctor every morning, or if there's a problem, can get immediately, does that patient need to go to the hospital, or is it just something that can be taken care of home? So I do believe that there's a lot to do, but the end-of-life care is a discussion that this country needs to have. And it's a serious conversation, because there are many patients that are in ICU that will never have a chance of surviving. And the cost to those patients and to the hospital is extremely high. While we were talking, I was just looking, and I was doing a little bit of math for my health care. We have government health care, obviously, and I pay $159 a month. Then we add up my co-payment for my insurance. By the way, I've got good insurance, Blue Cross Blue Shield. I've got everything in there, bells, whistles, and everything else like that. It comes out on my share $2,258, which I feel is reasonable, for a year for a single person. So I think one of the things that I was interested in, Mr. Darshare, on your testimony that you're paying 85% of the premiums for individual coverage. Do the workers actually know how much you're paying out, for that care? How transparent are the insurance companies about their costs, both to the employees and to the employer? These are things that need to be worked out and to be looked at. I know that we were trying to have a bill come through on the federal level anyhow, where a business like yours could connect with many other businesses. And I think the National Association of Manufacturers Retail would like to see that, so they can bring it up to the larger employee companies that have lower costs. And I would just like your opinion on that.
Yes. Yeah, thank you. Yes, they do know the cost. I do pass it on. I'm at a critical junction of whether I can continue to play family, because that is just a phenomenal cost. I cap it at $50 a week that comes out of their paycheck, and it's been that way for years. It just cannot pass anything more onto them, because my employees are, lower middle class. A polling system, anything to reduce costs would be, very attractive. I know in Maryland, the state that I'm from, of course, that they regulate pricing. The state regulate pricing to the insurance company of groups of 50 employees or under. So my rates are somewhat controlled in the state, and I don't know what the impact that is compared to other plans. Did I answer your question?
It does.
Okay.
Thank you.
You're welcome.
And I'll throw this out to anybody. To what extent do you believe that health care costs are contributing to our current economical crisis? And I'll throw that out to anybody out there.
I'll take a shot. Well, I think that if you look at it on two dimensions, certainly if you look at it from the business perspective, rising healthcare costs are one of the less controllable aspects of the overall level of compensation. And it's done two things. One is that it leads to lower wage increases for individual workers. And two, for some companies that can't fully shift it back, they're finding that it, A, cuts into profits, B, cuts into their ability to make capital investments and improvements in their operations, and three, puts them at a competitive disadvantage in a global economy. So from the business perspective, I think it's clear. If you look at state and local governments, it's a major source of uncontrollable growth in those budgets, which means that it's either going to crowd out other state and local functions, or you're going to have to look at tax increases to pay for it. We've seen the budget numbers at the federal level. Medicare is the big issue in terms of entitlement reform, in terms of driving the budget deficit. And we need to have a coherent strategy that really deals with the core issues around why Medicare spending is rising and really take that issue on. And just finally, from an individual standpoint, we know that the trade-offs that families have to make in terms of do they keep health insurance or not. We know the numbers, and we can debate them on how prevalent of a role that plays in individual bankruptcy cases, but it's a big deal in terms of people losing their homes when they can't afford to pay their bills. So I think it is a major component and contributor that has to be to the economy. It's 16% of our overall GDP, so it really is a key issue that at the same time we're dealing with trying to find ways to fix the economy, we really need to get to the core of this issue of healthcare costs as well.
Gentlelady's time has expired.
Thank you.
Thank you very much. Turn to the gentleman from Connecticut who's made a significant contribution already in the area of pre-existing conditions. Mr. Courtney for 5 minutes.
Thank you, Mr. Chairman. And I would actually like to follow up on that issue a little bit with Mr. Thorpe, because I mean, your description of the free riders, the spouses who kind of gravitate towards lowest cost, I mean, really that's not the only issue for families. I mean, to take a hypothetical, in Connecticut, if somebody works at Pratt & Whitney, we're the large group plan, and the spouse is a realtor, and if you're expecting the self-employed realtor to, pull her or his burden, I mean, the fact of the matter is there's obviously a huge pricing difference in terms of the small group self-employed market versus the group. But frankly, there's also other issues in terms of the fact that pre-existing condition exclusions, high deductibles, I mean, which really undercuts the ability of wellness and prevention programs. I mean, really, it's not it's a totally rational decision for that spouse, and to sort of characterize it as, quote, free rider, I think is a little pejorative in my opinion, and frankly, it kind of, again, I think there's other structural issues in the market that need to be fixed to help families not sort of go in a direction that maybe is more burdensome for the large group plans. I just wonder if you could comment on that.
I completely agree with you, and that's why when I said it, I characterized it very carefully as some call them free riders. And this was just a description of the facts, the underlying reasons why it happens. I completely agree with you on that. There's good reason for why, irrational reasons for why a spouse would choose to go to a more generous policy at lower costs. I think the solution to it is some of what we've been talking about here. One is to get more comprehensive coverage to everybody through the workplace. And that obviously, if you think about it from the employer that's offering the coverage, they really have a triple whammy. Healthcare costs a lot anyways. They have built into the cost of their premium 2 to 9%. We can debate what the number is due to uncompensated care from the uninsured. And they're covering the costs of spouses that are working for companies that don't offer. So a way to deal with that is to expand coverage, you get the uninsured piece out, broaden the employment-based system so that employers that don't offer coverage or individuals that don't get coverage through employers can now afford to do it by requiring them to acquire coverage, but making it affordable. Provide the requisite government funding to make sure that they can afford it. And that way it spreads the burden out more evenly.
But it's more than a funding issue, which it clearly is, and I think all the witnesses have pretty much agreed on that. But it's also, I mean, we have to do something structurally to the market for the small firm end of the system. I mean, and the President has talked about this, that we've got to create some kind of pooling mechanisms that allow the risk to be spread out and the harshness of some of the underwriting rules to be relaxed more, because I mean, there's just no question that if you're somebody who's got any kind of chronic illness and you're out there in a small group area, I mean, you've got a major problem in terms of trying to find a plan. And what all the mandates in the world and all the subsidies in the world are really not by themselves enough to sort of fix that problem. And I don't know if Mr. Winkler, you want to focus on that in terms of whether we've got to create structures for the smaller end. I realize you do group as a general rule, but.
Well, I think, and Mr. Derbyshire underscored the challenges that the employers who really are squeezed are those sort of in the middle of that under 50 group, which in most states are already pooled in some capacity, as he described in the state of Maryland. But it's the employers just above that on up to the large insurers that organizations like Hewitt work with, who find themselves, I think, struggling with some of the purchasing dynamics that you described. That does logically make it such that a married couple would look and say, my coverage from XYZ large employer is more attractive for us as a family than the coverage underneath. And there may be sort of group cooperative or pooling mechanisms that could work in that smaller above 50 lives market that could help.
And Mr. Derbyshire, I mean, you must talk to a lot of your colleagues in the business community. I mean, where these pricing differences and pre-existing condition rule differences are much harsher than families and individuals who are in companies that have large groups to spread out the risk.
Well, I don't know. Again, in Maryland, they do regulate it, that in the Maryland system with a health maintenance plan, that you have to accept everyone into the plan. So there isn't preconditioning conditions that would leave you out of the plan.
Took him a while.
Am I answering your question?
It is, and that's by law and by government intervention.
Right,
That's
exactly,
the case.
exactly.
And that's helpful for us to know that
Yeah,
in terms of dealing with that problem.
Yeah.
I think it's one of the reasons why the gentleman introduced his legislation in the last Congress. I know that he's once again taken a step forward on that. And I think the President has expressed his interest in the same concept the gentleman from Connecticut is interested in. So I think we'll move forward. The gentleman from Michigan, Mr. Kildee, is recognized for 5 minutes.
Thank you, Mr. Chairman. Thank you for assembling this panel. You all collectively and individually have been very helpful, and I appreciate it very much. I'll address my question to the Go Blue friend down there, at the end of the table. In Flint, Michigan, employers for years would seek to hire those whose spouse worked at General Motors. General Motors basically is self-insured using Blue Cross Blue Shield as their fiscal agency. That, along with their own direct employees being insured, adds about well over $1,000, sometimes $2,000 to the price of a car. Now, General Motors right now is in the midst of trying to qualify for additional funds under the Troubled Assets Recovery Program. One of the things they are required to do is to change their, they've switched over their health program now to the union. And it's called a Voluntary Employer Beneficiary Association. But the federal government now is asking them to give half the money for that in General Motors stock rather than dollars. General Motors stock is not that great a shape right now. This is an enormous company, a large company that I talked to Rick Wagner yesterday. He's spending so much of his time trying to settle this health care program. What can we do, first of all, to relieve a company like that is really, really in difficulty, and let them get back to the business while keeping up their responsibility of producing cars? Do you have any suggestions of what we might do?
I appreciate the question. I'd sort of point to 5 things, and this kind of relates to the dialogue I just had with Mr. Courtney on this issue. And the 5 things that I would focus on would be, 1 is to move towards an individual requirement that people have health insurance. That 2, that you put in appropriate funding, federal funding, to make sure that it is affordable for families to buy insurance through another employer if they choose, or through a health insurance exchange if they want to go that direction. That then spreads the cost out in a much broader way. So at a place like, as I mentioned in my statistics, if you got half of the family sort of doubling up, and my mom got coverage through GM exactly for that reason, because it was a great policy. That's 2 things to do. I think the other 3 is that you've got to make sure, if you go in this direction, that you've got to require a guaranteed issue, that you've got to make sure that people, when they apply, they get a guarantee issue to it. The health insurance industry is certainly on board with that. We've got to reform how we do rates in terms of how premiums ratings are established. And you've got to find new pooling mechanisms to deal with issues around a lot of the inefficiencies around individual and small group coverage. The President has put on the table one approach through these health insurance exchanges. There's others that we could look at as well. But those would be 5 things that I do. And then one last thing, and it goes back to the healthcare cost issue. Those unions are now in a position of managing a pot of dollars. And unless they find a way to change the growth trajectory per capita spending in that union mix, those dollars are going to run out much faster than they think.
Thank you very much, Dr. Thorpe. I like your concise answer, and I just, again, think this has been a very, very helpful hearing. Thank you, Mr. Chairman.
Thank you, Mr. Kildee, for your participation. I'd like now to call on the ranking member for any concluding comments he may have.
Thank you, Mr. Chairman. Again, thank you to the witnesses today. It's been a great panel. A lot of discussion. I think that there is a universal recognition that we have a problem. There's not a universal recognition on what those critical details might be, and that's part of what we're about. So I thank you very much for your thoughtful presentation and your terrific answers to the question. And I thank you for the hearing, Mr. Chairman. I yield back.
Thank you. I would also like to add my words of appreciation for the way the witnesses have helped us on our project, our journey to try to learn more about how to fix this problem. I think everyone's comments were offered in the spirit of instruction and cooperation, which emanated from the White House summit last Thursday. We appreciate you picking up on that spirit. It occurs to me that our job is a huge one, and it's to convert a dysfunctional relationship between cost and coverage into a functional and positive one. If you don't control costs, more people become uncovered. They don't have health insurance. As more people become without health insurance, costs go up for that and a number of other factors. So we're going to embark upon an effort to try to figure out ways that we can reduce cost pressures on American families and businesses. We've explored several of them today. One of them is trying to find a way to get everyone insured, which I think is the top priority on the list. We've looked at increasing productivity in dealing with medical technology, which is very important. Each of the witnesses, one way or another, has talked about dealing with the chronic diseases that absorb a huge percentage of healthcare outlays. And I think we can find common ground on that. Again, I'm very pleased that each of the witnesses in his own way was able to start to tackle the issue that policymakers have failed to tackle for 40 years, which is acknowledging the fact that there is a significant cost to getting everyone insured. How do you pay for it? And I do think that the President set an excellent example by giving his answer to that question. I think you gentlemen have followed that example by giving your own in various ways, in various positions. And it's now up to us to do the same thing. If we are able to have a mature and intelligent process, it will lead to an answer, and I believe it will lead to the President signing a health reform bill in 2009 that will very much benefit the country. If we shy away from that issue, if we tiptoe around it, we'll be right back where we've been for 4 decades, which is describing the problem but not solving it. I think you've given us a very strong start to go about the business of solving the problem. We thank you for that participation. As previously ordered, members will have 14 days to submit additional materials for the hearing record. Any member who wishes to submit follow-up questions in writing to the witnesses should coordinate with the majority staff within 14 days, and without objection, the hearing is adjourned.